afternoon. It's 1 o'clock on the West Coast, 4 o'clock on the East Coast, and whatever time it is, wherever else you are in the world. And if you're listening on the podcast, this doesn't really matter. I'm Matthew Holt, head of the THCB gang. It's like this weird thing for those of you watching on the video where my video freezes and does weird stuff. So occasionally I'll pop in and out of the video. However, this week's gang, I have a small mighty lineup. We have a couple of late cry-offs. Sadly, Jen Benz and Casey Quinlan. Jen Benz can't make it, and Casey Quinlan not having one of our better health days. So we have actually a bunch of people on very, very recently. Ian Morrison, a health futurist, Vince Kuraitis, our platform analyst and expert, and Jen Goldsack, CEO of the Digital Medicine Society, DIME. So we're the gang for today. We will spend the afternoon, the next hour or so, chatting about various topics in healthcare, what we've been getting up to, and how we're doing it. So let's take it away. Well, hi, gang. I hope we're all feeling good and well and enjoying ourselves. Let's start the way we should start. I know we sometimes got away from this in recent weeks by going around and figure out what have people been up to, what have they been watching, what have they been doing, and what do they care about. So ladies first, let me start with you, Jen.
Well, always getting into trouble in one way or another, but
I guess you've been mourning for the last 4 days, right?
I've been horrified. I went up to Philly, and as we discussed a couple of weeks ago when I was last on crutches, the whole shebang, went the whole 9 yards, and it was a dark night in Philadelphia on Sunday. That was a rough one. Well,
to be fair, your team played pretty damn well, and it was pretty damn close,
It was
thin margins, right?
It was thin margins. Horrible goal at the end of the first half that I will talk about until we win again. But it was. I mean, here's the thing: it was a terrific game. It was an absolutely terrific game. It was close. It was interesting till the end. It was tremendous football the whole way through. So, had I not been a diehard fan, I would have been delighted with the quality of the match.
Well, all I know is that having watched that game, I no longer know what a completion is. A bit like watching soccer. I don't know what a penalty is anymore.
I don't know. I would have thought a definition of a 250-pound man landing on top of you and you not dropping the ball would be a definition of being in control of it. But apparently that's not the case. Don't get me started.
On the other hand, I think the one where the guy knocked out the pass that I thought was a completely pass, and they ran it in for a touchdown against you guys. Swings and roundabouts. Anyway, all right. Return to healthcare, if you can remember that topic. Yeah. What have you been up to in that world?
Oh God. Oh, me.
Yes, you.
Yes, me. Still
we didn't do the healthcare part yet. We've only talked about football.
So yes, have done some of that this week as well, and actually very proud of some resources that we launched yesterday. We were actually thrilled to host FDA Commissioner Dr. Califf here at DIME yesterday as we released some resources promoting diversity, equity, and inclusion in digitized clinical trials. And there are a couple of things that he said that sort of resonate with how we think about all of this at DIME, but I think warrant repeating, which is, there's no technical reason why we can't create a system that works for everyone. When we think about the digital tools in the toolbox, there is a way to be thoughtful about the way we develop those tools, the way we deploy them, and the incentives we put out in the market in order to reap the benefits that technologies afford to reach every person. So what does that come down to? It comes down to, a willingness to dig in and to do the work. And, are there the incentives there to do it? So obviously yesterday we put out a suite of resources that we feel strongly can help people realize that promise today. But it was interesting to have that call because I also popped into the Federal Health at Home Tech Summit that was hosted by BARDA's Drive yesterday. Very similar conversations. And so it's sort of front of mind for me this week. How can we think about using these tools to make access to the care we receive and the quality of care more equitable? And, it's not a tech problem. Those are the two things we're thinking about this week.
Yeah, that whole hospital at home, clinical trials distribution, getting more people included, is a big problem. And I just had a conversation about specialty pharmacy, which is kind of related as well. There's a lot of issues about how do we manage the care of people wherever they are, and that's something we've promised a long time, right? The continuum of care. Yeah. I've been hearing about that from Ian since 1991 or something, but not sure we're there yet. Vince, what have you been up to? What have you been looking at?
Yeah, so I'd kind of like to go back to the conversation we had earlier and do part two of Oak Street Health. a little wiser. I've had a little bit of a chance to do a deeper dive into understanding what they're doing. And the question I'll pose provocatively and hopefully constructively, though, is, are we about to learn or relearn a lesson that we learned in the disease management era 20, 25 years ago? So bear with me. I'm going to have to set this up a little bit. Okay. Back in the mid to late 1990s, health plans had no clue what to do with heart failure patients. And along came these point solution carve-out companies who cared only for heart failure patients and said, we'll take them off your hands for a fee per month, and we'll deal with them. And since the health plans didn't have the understanding and the infrastructure, they just said, great, you can have these patients. So to deconstruct this a little bit, the typical heart failure patient, how do they get into trouble? It's probably someone who's a little bit older, generally perhaps in weaker health, and they eat a can of Campbell's soup over dinner, and it's got a couple thousand milligrams of sodium, which helps them retain weight. They wake up the next morning, they've gained 5 pounds. And I'm not a clinician, but my understanding is what happens clinically is that the heart can't process pumping blood across that extra weight. They go into heart failure, they wind up in the hospital, and the health plan winds up paying $10,000 or $15,000 for that hospitalization. So what did these disease management rocket scientist companies actually do? Well, the first step is you talk to patients and you say, you've got heart failure. You shouldn't be eating cans of Campbell's soup. Okay, that's step number one. And then they came in with, they gave people scales, and eventually they gave people electronic scales that would connect back to a call center, and they would say, weigh yourself every morning. And if you've gained 5 pounds, we'll have a nurse call you. And then the next step became, we'll send a nurse out, a home health nurse, will give you a shot of Lasix and prevent the $15,000 hospitalization. So what was originally viewed as rocket science, I think as it became well known, was really a combination of a social model, educating patients, and technological infrastructure and a mechanism to be able to deal with crises that were inevitable. And I pose the same question about Oak Street. Is this what we're going to see? So, 10, 15 years ago, we really had no collective knowledge about how to deal with some of the most complex elderly patients who had multiple chronic conditions. And, this is the 1% or the 5% of the population that's accruing 50% of healthcare costs in any given year. So what we've seen is a number of companies, Oak Street, I think, has done it, ChenMed has done it, and they built a combination of a social model. You go into a ChenMed center and they've got 1,000 feet of what they call community space, where people meet their friends, they come in, they can have informal discussions. I don't know what else goes on there, but there's definitely a social aspect to this. And then you have the care model, where you work proactively to be able to avoid, and OakMed's statistics in their S1, they claim they can reduce hospitalizations among this high-cost population by 50%, which is really just a darned amazing number, and it ought to scare the daylights out of health systems if this model, and it is becoming more pervasive. So the question I'll pose, and maybe we can discuss it as a group later, is, are we relearning the same hard lesson where we originally thought, what was clinically not understood now is becoming more understood and is beginning to diffuse, and in turn, frankly, becomes a business model challenge to companies like Oak Street, who are going to have a lot more competitors, and presumably or potentially then have to compete on price. The last point there is that Oak Street, a lot of their competitors are health plans that are not part of the CVS network. They're other health plans, and are these other health plans eventually going to develop comparable services or contract with other companies? And I lied. Actually, I have one more point. Our colleague Jeff Goldsmith recently wrote. I think he wrote a really good question. What's the footprint of Oak Street centers with the population that CVS Health insures? That'd be interesting to see a map, and if there is much of an overlap, is CVS going to be able to reap the benefits because they're insuring this population? So I hope that made sense. I've been around long enough, and you too, Matthew, and Ian, I know you've been around. Jen, I don't know you yet, but you probably haven't been around to have relearned this lesson. It's just going to be a hard lesson to relearn.
So I think that's a great point, Vince, because remember what happened to all those disease management companies, right?
They went by the wayside.
They went by the wayside because they couldn't actually,
no one believed their ROI.
The ROI didn't exist as much, and when they made promises, they made the promises they made didn't turn out, and they didn't make it into Medicare or the VA for as long as they should. Even though, and I think that there is a big question, if you do all this great stuff, does it actually save you any money in the end? There are obviously some other thoughts about why Oak Street and Chemba and others are working with now. Chemba's now working with Humana. Oak Street obviously been acquired by Aetna. There's a lot going on there, but I put a Matthew's tidbits in the THCB Reader newsletter today about that, which we'll actually make it on the blog when I get my act together and copy it from one place and put it into the other. But basically, the answer is there's the other 85% of the dollar they need to get at. Ian, what have you been up to? And I think both Jen and Vince have sort of got us towards this spread across the healthcare continuum and how is stuff being managed. So we should definitely get into that in a second, but you may have other things that have been on your mind as well. You need to unmute as well. Ian, you need to unmute.
Sorry. It sort of relates to what Vince was talking about. Matthew, you and I have been in the middle of George Halverson's stream of consciousness. I mean, he's turning into the James Joyce of American health policy. I love George, don't get me wrong, but his I thought
some of the stuff you've seen has been like after I said you've got to get rid of the extra 50,000 words there.
Well, he is resisting editing, but anyway, no. But his three-legged stool piece that came out today, I guess, in the blog or yesterday.
One yesterday. There'll be another part, I think, coming tomorrow or the next.
Yeah, I mean, it's important to reaffirm that, and just to remind people who haven't read it yet, the three legs are basically Medicaid expansion, exchanges, and Medicare Advantage as an engine for the kind of transformation that Vince is talking about. And then he points in that to the whole special needs plans and so forth. But I'm getting ready for this Vizient meeting in a couple of weeks where I'm moderator. And so I'm doing a lot of calls with CEOs in preparation for that. And they're all health system folk. And I'm sort of struck by and this is a conversation we've had over previous weeks, the fact that the plans seem to be doing great. You look at United's earnings and Cigna's earnings, but every health system CEO I talk to is sucking air right now. And they're not short of things to do, right? I mean, they're full. It's just that they can't deliver care. I mean, one CEO sent me his weekly newsletter that he sends to his board, and his labor costs are up 10%, right? You can't manage that when revenues are basically flat. So there's a real issue there. And I think when Jen was on last time, we talked about this. I think it's the opportunity for digital health, quite frankly, is they're leaving a lot of money. The systems are leaving a lot of money on the table because of throughput on specialty services. People need care, and they need care beyond primary care. But I gave up trying to get through to the Palo Alto Clinic this morning by phone, and eventually got on my chart and doing battle on my chart. I think since we came on, I've had 5 my chart messages from both Stanford and Palo Alto Clinic.
Are they charging you $65 each?
Yeah, yeah, I'm fee for service Medicare, so whatever they're doing, I don't care. But anyway, so I mean, it's that juxtaposition of who's the winner and loser at this. And then the other piece that came out yesterday that caught my eye was Bill Frist's, what does he call it? The Health Affairs Council on Health Spending and Value, where he gathered some worthies of, people we all know and love, like David Cutler and other smart economists together to talk about, where the opportunities for improvement and value are. And it was really very focused on administrative waste motion. And that, to me, there's an irony there in the sense that a lot of what the plan overhead is one of the things that distinguishes this country from other places. So we've got a lot of people faxing things to each other, doing all these different, sort of interventions administratively, and other systems are relying on very, very simple fee-for-service schedules that are ratcheted down on a price basis. And, I think maybe a third of the difference between us and other countries is that administrative waste motion. So I think it's right to draw attention to it. I guess where I'm going with this is, it seems to me there's a battle over scarce resources about to happen as the vice on healthcare gets tighter with things like these top-down accountability things that Newsom and others are doing here in California. And which part of the ecosystem will get squeezed the most is the question mark going forward.
So I bring in. I won't go off into my Twitter battles of the week yet. Maybe we'll get into that later. But there is the piece. I think I just want to quickly sort of summarize the little piece I wrote today, which is nothing brilliant. It's what Don Berwick and Rick Gorfallon have been saying for a while, which is the reason that the plans are now getting into the wanting to acquire providers is because they're looking at, they're limited to 15% of the dollar by law at the sort of the top end, and if they can get into the other 85%, there's an opportunity for them to essentially extract more as an organization. That obviously brings them back to being more like Kaiser. So if you look at Kaiser's numbers, they always said they were 95% of the dollars went down to medical care use, and you go, well, is that really true? Because they actually own the medical group and the hospitals as well. They're playing games. How much was spent at the plan level, et cetera, et cetera. And if I go back to the piece which I looked at for Humana when they were looking at their groups like Oak Street versus their fee-for-service players, providers underneath Medicare Advantage, they had very little price difference between them. So it always seems to me is that this is about the movements are like who can get into more of the dollars and who can get access to more of the dollars, and then is there something that can be done to radically save the money, or do we have a repeat of what happened in the 90s that Vince raised, versus do we have a repeat of what happened, versus do we have a real change where we can start moving stuff around, and then at some point moving people away from higher price stuff, and at some point maybe reducing the amount we spend on that high price stuff, which includes going after high price drugs and going after high price specialists and all the other stuff, and which is the harder thing to do. So I think we've laid a table here of a pretty complicated piece. But Jen, I wanted to go back to where you started this, right, which was looking at hospital at home, looking at distributed clinical trials and some other stuff like that. Part of the question I always have is, there's a lot of conversation, and Sachin Jain wrote this great piece about 2 years ago about the difference between the innovation health economy and the actual health economy. A lot of people like us talking about, distributed clinical trials and hospital at home and, digital stuff. And then when you look at what's going on in real care provision, there wasn't that much change. How fast and far do you think this change is? I mean, and then I guess the bigger question is to get into what do you think it's going to do regarding how we actually pay for stuff?
Yeah, so it's interesting. So when we founded Dime back in 2019, we've been around forever. It was
that was before pandemic.
It was
remember
before
that
times. So at this point, it was just the before times. It doesn't matter how before in the before times. So at that point, we saw that actually the medical product developers, so, pharma industry and others, were the leading edge of actually applying digital innovation into their day-to-day practice. Then came the pandemic, and what we saw was there was a sort of push across the entire healthcare continuum. And what I've seen, so this is my commentary post-pandemic, is that there's very little change, in my opinion, from what we're doing in drug development vis-a-vis what we're doing on the healthcare delivery side of the shop. I'm seeing much greater innovation for change at scale, and much more compelling use cases on the care delivery side of the house than I am on the research side. And so, put that in real terms, if we say, how far are we towards building clinical trials around the patient and not the clinic? Nowhere near as far as where we are, and certainly not moving at the pace that we are when we think about building care around the person and not the clinic. So I think it's interesting to have seen this uneven embrace. And I think it comes back to some of what Ian was mentioning. There's going to become a point where it is no longer possible for us to deliver care in the way we have before, because of costs and because of clinician shortages, so on and so forth. And I think that everyone knows that it is obvious and inevitable at this point, and they're leaning into it and they want to be first. And I think that there's still that reticence in the very traditional medical product development environment, which is incredibly highly regulated, which is defined by conservatism, which isn't to say there aren't these sort of nodes of tremendous innovation, but it's not happening at scale like it is at healthcare.
I'm curious, Jen, what do you see as on the delivery side some of the biggest innovations?
So Vince, we were chatting about this a little bit when Ian and I were last on together, and what we see more than anything is this idea of virtual first care. And we use virtual first care really intentionally. And this is not to say virtual only care. I think the reality is anyone who ever thought it was going to be virtual only was wrong, and now realizes they're wrong. And we are driving towards some kind of hybrid approach. But we're seeing tremendous innovations there, not just in the way we care for people, using the full stack of both technology products and humans, whether those humans are coaches, whether those humans are actual sort of clinical care providers. We're seeing great success there, not just in terms of access and outcomes, but we're seeing some real innovation in terms of how folks actually pay for this care, how they're able to use sort of bubblegum and tape and use the existing coding system in order to really push through. It's taken, in some cases, based on what we're seeing, 1.5 years of thoughtful partnerships between some of these virtual first care providers and, the large payers, but they're making progress, and it's proving to be very successful indeed.
How much of the virtual first stuff is sort of moving towards the sicker people that we talked about with, you mentioned hospital at home earlier, and obviously there's been a big bump in that. And what surprised me about hospital at home, when you talk to Medically Home or some of the other leaders in that group, is that they first off thought they were going to be the enemy of the hospital, right? They were going to be taking stuff away from the hospitals, and they'd be working based on behalf of medical, capitated medical groups and others, and being a sort of cheap alternative for hospital admissions for the people who needed the hospital admission. So if Oak Street could stop 50% hospital admissions, but if the rest of their admissions they can admit people to the home and it's cheaper and better, faster, and what have you, that was kind of where they thought they were going. But they ended up, partly because of COVID, right, delivering a lot of these at-home services to hospital systems, who were then billing for them back into the way they're billing for them. And I don't want to start talking about price yet, but later on I will tell you I've just done my January. looked up my January set of claims for my kids, and my daughter had a visit with a UCSF specialist, and the billing is not flat, and even if there is no flat tax in American healthcare hospital billing yet. But let's just go back to that point. How fast is this virtual first approach happening for everybody? Because when I look at the numbers, it seems to me that we're doing a lot of telehealth and mental health, and the rest of it is scratching around a bit. So I don't know how much of I'm back to are we really moving the needle, or is it is it just us people talking about it?
No, I mean, I would say, so take a look at our virtual first care directory. We've got over 160 companies with demonstrated proof points of reimbursement pathways and care pathways that are proving effective and efficient today, and at some sort of level of scale. So this isn't sort of a a pilot in the car park in a sandbox, right? This is actually real. And so I think that's worth taking a look at. I will also say that is, from what I'm seeing, much further ahead than hospital at home. And I think that the beauty of virtual first care is that you can be fit for purpose, regardless of someone's place, their tech literacy, so on and so forth, because it is a full stack solution. I think some of the things holding back hospital at home are some of the things that continue to hold back decentralized clinical trials, right? We were talking to a top 10 pharma, and it's not the tech that's stopping them doing decentralized clinical trials. They spent a fortune and ended up with a ton of coagulated blood samples, right? That's not a tech issue. That's like, can we actually get a high quality, vendor who can actually deliver these sorts of things? And so they had the tech piece. It was the more, the traditional samples, the traditional sort of labs and imaging and path that you need that you can more readily get within the hospital. That's the challenging piece for decentralized clinical trials. That's the current challenge with hospital at home, coupled with there's much more of an equity question when you come to hospital at home, because not everybody's front room, Matthew, as you and I would call it, not everyone's living room can accommodate a hospital bed. Not everyone is safe at home. Not everyone can afford 24/7 heating or air conditioning, at home. Sometimes it's nice to be in the hospital and get 3 square meals a day. If you need help toileting, you may not have a care partner who can help you with that at home. These are the sorts of things where I actually think there are many technical tools that power hospital at home, as well as there are many technical tools that are necessary to power decentralized clinical trials. But the human element still needs to be present and in person in a way that it doesn't have to be when you think about virtual first care and an interdependency between in clinic and virtual.
Jen, are you tracking on the whole virtual first stuff, the proportion that are sort of de novo solution offerers that you described last time versus existing health systems with virtual first offerings? Because I've seen some studies, and I don't pretend to know that this is definitive, but from the early part of the pandemic, which showed that the most frequent use of telehealth, forget about the behavioral health stuff for a minute, because I think that's a special case, but the most frequent use of telehealth was with existing care providers. I mean, can you comment on that, about just the relative balance between, is it like my experience of telehealth, which is exclusively with the Palo Alto Clinic in Stanford, right, who I was going to anyway, versus I've never used Teladoc or any other external vendor. But can you speak to that, kind of how that universe parses out?
Yeah, so
and Matthew's gone all yellow submarine.
He's come over all green. So it's a really good question, and I believe those numbers to be true, right? Which is what we would describe, and it's a little bit pejorative and perhaps intentionally so, what we might describe as bolt-on telehealth, which is you're doing exactly the same thing that you would have done in the doctor's office, only you're doing it over a forum like you and I are speaking to one another, Ian. Right. So we're not breaking in any way the sort of chokehold, if you like, that the doctor-patient interaction has on the way we deliver and the way we pay for care. We see that as being different to what we would describe as virtual first care. And Ian, we've talked about this, again, quite provocative, that, that bolt-on telehealth is going to, at best, render an opinion, right? What we think of as virtual first care providers is having that navigation piece, being able to fully connect you with a solution, whether that's not just we'll put a prescription in your MyChart, but it's actually we will get the prescription to you, or we will navigate you to the specialist that you now need to see, or we are going to set you up with that imaging appointment that you need, and we are going to sort of white glove treatment you all the way there to make sure you have it, and we will be there to receive that information. So we define virtual first care as fundamentally different to this bolt-on telehealth, which is not to completely rag on bolt-on telehealth, because I know that the larger care systems are using it quite effectively for load balancing, which gets back to the throughput conversation we were having before, but it's not going to change anything because it doesn't break that chokehold on the doctor-patient visit.
My metaphor for all this is like a volcano forming in the middle of the ocean, where it used to be ocean and now the volcano comes up from under the water, is forming an entirely new ecosystem. And lava flows and the volcano gets bigger, and over 50 years we'll have Krakatoa, but today it's just a little bit of a bump. And interesting, I had looked at your website, Jen. The last I saw was 139 companies. You're now telling me you've got 160 in your ecosystem. So, over the course of a couple of weeks, you've obviously had some new membership. And these.
Well, they may have just updated their website. You never know.
Exactly. It's like when you're. It's like when you're trying to break the world record for the high jump, and you know that every time you break it, you get a bonus. So you do one at every competition through the course of the season.
Yeah. And what I think is really strategically worth noting is a lot of these companies really are trying to work outside of the existing medical system. There's been some really good articles, particularly by Brendan Keeler, who's kind of the API expert guy, around how hard it is for these early stage companies who are trying to do virtual care to use and to work with the existing EHR vendors. And in turn, there's, I can't remember the names off the top of my head, but there's a number of these companies that have built their own EHRs that are really independent. And Oak Street is an example of one of them. I think theirs is called Canopy, if I remember. But again, it's a whole new ecosystem. It's working outside of the existing healthcare system. And to tie it into what you're saying earlier, Ian, I mean, this is really just one more cause to be really. I'd be pressed to be a hospital administrator these days. It's not a very optimistic scenario.
Oh, they're all retiring, I think.
No kidding. Well, there is sort of those two things going on, right? And you both highlighted them. And so I was thinking of there's a guy who I should have on THCB, who's a buddy of mine called Lyle Berkowitz, who many of you run into.
Oh yeah, no,
sure.
Lyle is running a company called KeyCare, and what KeyCare is it's a medical group. They've got an Epic. They've got an instance of Epic and a CMIO, and it's a virtual medical group, and it's designed to go to big hospital systems. I think they've got, I want to say they have University of Michigan or one of the Michigan systems as their first customer, but some others on the path, and basically be exactly what Jen said, be their load balancing medical group. Move data back and forth between their Epic systems to make sure that they don't lose referrals of people out to the world of whatever it is, right? On the other hand, you've got all these venture-backed companies who are particularly, you do have obviously the Teladoc's and the Amwells and the folks who are playing both sides of that street by both providing technology to the incumbents, but also on the other hand, having their own medical groups and moving stuff around and starting to do virtual first just with health plans and starting to build that ecosystem. And you have a whole stack of venture-backed, specialty only companies doing just GI or just asthma or just epilepsy or what have you. And and if you go down the path of people doing just MSK, the venture money that's gone into some of these different verticals, especially verticals, is huge. And in the end, none of that stuff works. I mean, the thing we're getting back to is none of this stuff works on the sort of the new entrants if they don't manage to extract market share out of the hospitals and the specialists. It's what Ian told me in 1993. American healthcare overpays its hospitals and its specialists, and the job of managed care is to extract the money from them and put it in the managed care executive's pocket, right? Which is basically what it was then. I know things, the managed care executives, after some iteration succeeded. If you look at how United is doing and Aetna's doing, but I mean, that's kind of the game. So I think we have these different things. It's still to a certain extent is how fast are we moving the care out of the traditional centers where it lives, whether it's clinical trials, hospital at home, regular care, virtual first, whatever it is. And then the other question is who controls that, right? Does it end up being controlled by the current hospital systems, or does it end up being controlled by new third parties, or does kind of what's going on with the Aetna, CVS, Optum, United, Humana thing where they're getting far more into the provision of care.
So if I could maybe just the way I'm sort of, and Matthew, I mean, I've been preaching capitation and value-based care for 25 years, but what I'm sort of talking with CEOs about is to say, forget about that. You're not.
It's 35, by the way. It's not 40.
Yeah, 40 years. forget about that rationale, because you're not capitated. You know, somebody up the food chain may be capitated, but you're not. Do it in the name of throughput, because you're not short of things to do. Everybody I know is full, you know. You know, I think maybe last time I told you the story of my children's hospital that I was working with, who basically turned away 1,000 cases because they had no capacity. You know, and they were turning away, you know, those cases that would be 20-year sinecures financially, because, you know, the 550 problem is even more extreme in pediatrics. You know, is more concentrated. It's a few kids who have a very long lifetime expenditure trail. Anyway, but so the argument I've been making with a lot of CEOs is, okay, don't embrace this virtual first or hospital at home in the name of, you know, this is your business model. It's your throughput model, right? It's not a value-based care deal. But the real question is the one you asked, Matthew, is who gets to control it? And what worries the CEOs on the virtual first thing is that they will be left out of the party in terms of those referrals and the stuff that they really want to do. And the other big vulnerability that we haven't talked about in the last couple of weeks is site neutrality rules, because that is the cat amongst the pigeons. You know, I remember giving a talk for Bob Wachter up at UCSF and saying, you know, you guys are happy to have the $5,000 MRIs, right? And he said, yeah, no, I mean, that's what's cross-sub. You take that away and the math doesn't work. But there's a lot of site neutrality ruminations going on in Congress and amongst payers. Just as recently as today, there was a whole Twitter feed on that from Arnold Foundation funded study. Anyway, I'm ranting here, but the point is, in the name of throughput is the reason why some of them will do it, but they have vulnerability on the payment model because of the concern that they're going to either be left out of cases because of primary first, or that site neutrality will kill the economics when they do actually get the patients.
Okay, so say one more thing about site neutrality, how would that actually work?
Well, site neutrality basically is that, you know, for procedure-oriented specialties, if you buy a cardiologist, you can, you know, a cardiology practice, you can charge a hospital-based fee for something that's done in the outpatient environment. So take an example like Barry Arbuckle, who runs Memorial, probably one of the best run value-based systems in the country. He's got all of these ambulatory surgery centers and outside outpatient environment sites of care, which are not under the hospital license. So he's not playing the shenanigans of getting a much higher facility fee on top of the technical fee. So site neutrality is a set of principles of payment, which says, I don't care whether you're a hospital or a doctor's office. If you're doing procedure X, you get paid X, right? End of discussion. That really impacts the economics, particularly of academic. Well, that's, you got UCSF, Bill, dude. That's what you're seeing, site neutrality in action.
So I've just
lack of site neutrality.
I think I mentioned this a while ago, but I just had another re-up. So last year I saw both telehealth visits, right? for my back pain. I had two identical telehealth visits, identical length of time, identical conversations, identical me wandering up and down the office behind me, you know, limping and showing what my situation was. And I think one of them, Blue Cross Massachusetts, paid $225 for, and the other one for the non-UCSF one, and for the UCSF Academic Medical Center, I think they paid $800. My daughter, who's decided that our deductible was going to go quickly this year, apparently needs her tonsils out, which I bet back in your and my day, Ian, in the UK, that was like you got admitted to the NHS hospital for the night, they locked everyone's tonsils off and stuck them out the front door, and no one noticed. But the consult for that, the pediatric ENT doc, from the UCSF was, I think, Blue Cross Massachusetts just paid over $1,000 for that one consult. So, that you're talking probably an hour or so in the office. You're talking about, the fact that those academic medical centers are able to charge well-insured employer-based people, a lot more than typical private practice docs. And I think I don't know how much that's baked into the site neutrality around the extra fees they're charging. I haven't been able to figure out how much of that was the doctor's time versus a facility fee or whatever. But we're talking about an office visit. We're not even talking about actual procedures being done. So I think if you take it from site neutrality to we're going to pay a flat fee, across the environment, that changes a lot for every hospital and proceduralist. But it doesn't really get us to the next point of like, okay, do we use these platforms to do kind of capitation from the top and squash it down? Because there is a lot, as with half of Medicare, and there is most commercial, which is not capitated the way we used to think about it. Vince, you were trying to get him.
Yeah, so I look at this site neutrality from the standpoint of John Q. Public. I mean, is John going to buy this argument of we're going to pay the hospital more because they're the hospital, because they're big and bloated and inefficient? I mean, I just don't see that argument going very far.
Well, it's been the case for years, right? It's not like
isn't the point that it's being abused, right? Which is as they've gone around and they've been buying up all of these sort of freestanding clinics and practices. Like you can walk into a hospital and you can take a look around at the number of staff. And I don't love it, but you could imagine why the facility fee may have a premium. Oftentimes they're in more metropolitan areas. It's more expensive. You need more staff. I don't love it, but I can buy it. But when you start applying that to, everything that you've bought on a sort of M&A spree, that's where I think the challenge is coming from. And I would be thrilled to see that roll back. I also think there's another side of the coin here as we do think about these sort of virtual first care providers, and they make quite a compelling argument, and they don't think it should be anywhere near a sort of brick and mortar facility fee, but there's a strong argument, in my opinion, for some kind of fee to make sure that you're doing the necessary R&D and platform maintenance to keep things like security and such up. Again, it doesn't rival what you would expect to see at a facility fee, but the idea that there's a presence or absence of a fee and it's simply not available to a virtual first care provider doesn't actually make sense given the nature of the infrastructure that they maintain. And that infrastructure is as secure as your doctor's office because it is your doctor's office, and they need to be sort of paid for that one way or another.
Right. Yeah. And I mean, having spent a lot of time with AHA leadership over the years, the reason that their defense and argument in defense is that, they have to have trauma centers and ER facilities and all the other apparatus and burn units that is not burdened on a doctor's office environment, and hence this is how to pay for it. But I'm more sympathetic to people like Arbuckle who are saying, what's the right thing to do in the long run? And the right thing to do in the long run is to get the cost of care down so that if you are in a site neutral world, you can survive. But so I'm with you in that, Jen, but I will tell you that this is a big screaming deal for the AHA because the math doesn't work. If for most health systems, if you eliminated the fee arrangements on this is all in out. And remember, a majority of revenues now for every health system in America are on the outpatient basis. That's why there's the battleground is getting intense. Even Stanford is 57% revenue on the outpatient side. So the virtual first solutions that Jen describes are very threatening to the economics of traditional health systems.
But I go back and remind us that in the 1990s, a lot of the stuff that was threatening the Southern California medical groups that we used to hang out with back then, Ian, were very threatening to the hospitals then in terms of reducing inpatient bed days and all the stuff we used to talk about. Many of the same, things we're hearing from the IORAs and the GenMeds and the Oak Streets about how they're, doing better with coaches and reducing, and reducing the need for people to go to the emergency room and reducing the need for people to go to the emergency room and to get them into the hospital. And then the same thing is true. Presumably the virtual first is that you can stop a lot of stuff getting into the office. You can stop a lot of the more expensive stuff can be stopped upstream. In the end, though, as Ian says, the money gets spent on the people who are too sick who do need to be cared for, and maybe there are things you can do to prevent them and get people cared for more cheaply upstream, and the whole disease management argument that Vince started with 30 minutes ago.
Right.
But in the end, you've got it. If you want to cut the costs, everyone's fighting over that $5,000 MRI. But if you look at the cost of specialty drugs, look at the cost of specialty care, inpatient care, all those kinds of things. Every other country in the world just says we're going to pay you less, and suck it. And we haven't had that. Nobody in the American system has made that choice. And as far as I can tell, the attempt by the bigger plans and the bigger healthcare corporations like someone like a CVS, which is now in every part of healthcare, is to try to make sure they've got their hands on all parts of that dollar so they can move it around to where it's advantageous for them, rather than to sort of make it cheaper for the end employer or the government.
So I'd like to pose kind of synthesize and pose a question to you, Ian, and others. Is the question I'll pose, and I'll give some background, is, fundamentally, you're the hospital delivery system expert, Ian. Is there really a strategic positioning, a move that gets you out of this hole that you see yourself in? I mean, when I worked in the hospital world, it was death by 1,000 cuts. We had, the radiologists doing their own imaging centers, and we had nephrologists doing their own centers, and it was surgery centers. I mean, it was the physical world. And today, what we're talking about, it's death by 10,000 cuts. It's the virtual world. It's all these point solutions. You don't even see these patients leave your system because they're leaving and going to an online competitor. And your costs are up 10%. And you've got new competitors of big tech and big retail and primary care centers like Oak Street. And how do you, if you're a delivery system, what do you do? I don't see an optimistic scenario, and I'm curious whether you do.
Well, you merge or you retire.
Retirement is the solution to American health.
I got to go. I got a dentist appointment.
No, look, but I have to say, I'm surprisingly, impressed by my colleagues in the field who remain enthusiastic about it. I mean, here's kind of the things they're doing on the cost of labor stuff. I just listened to Gene Woods and Wright Lassiter do a thing this morning that they sent me. Going upstream in terms of trying to secure nurse staffing by starting nursing schools and strategic relationships with the nursing professions, so that they aren't going to be at the mercy of travelers again in the future. I mean, the people are taking this stuff on. A lot of people, and this is where Jen's expertise comes in, a lot of them are betting that they can partner with the appropriate virtual first and digital health solutions partners to, as I say, not in the name of value-based care necessarily, but in the name of throughput, so that they, loosen up resources for those things that an aging, obese society are going to want to have happen, that are inpatient and outpatient based, whether it be cancer care, cardiovascular, orthopedics, that you're not going to get done, necessarily in a solely outpatient environment. Although orthopedics, I think, is one example where it could be almost 100%, and as a lot of oncology care is now too. But I think that what I'm advising health systems on is go find the best partner, get through the list of Jen's 150 companies and do your due diligence. I just finished the thing for SHUSHMED. That was the punchline for that discussion with a bunch of hospital folk earlier this week.
Yeah, that's all fine for, working around the edges and solving some of your operational issues. What I'm not hearing you say, if I can push you in a friendly way, is I'm not hearing you say, what's the big strategic move? Is there one?
Well, I think a lot of them are ending up saying we're going to consolidate. And the critics would say that's a price increasing effect. But that is that's the conversation people are having, is the math doesn't work in the long run for us. So we got to be part of a bigger game. But the question I think you're really driving at, which is the important one, is will there be a time when margins return to 5%, 4 to 5%. I don't see that happening in the next 12 months, but I think it's possible with the amelioration in labor markets and supply chain stuff.
Yeah,
because the demand is there. There's no question the demand is there.
The advisory board makes the case that the labor issue is not a temporary one, it's a structural one.
Yeah.
And the argument they make, which intuitively makes sense to me, is that the hospitals are kind of down the chain of the desirability where healthcare workers want to be these days. And, you can look and see what happened to workers in the pandemic. You had people coming in with COVID and flus, and your workers aren't showing up, and you're understaffed. And sure, I'd rather go work for a virtual first company or Google or Oak Street. And I find that argument persuasive. I hope you're right, but it could be a much longer term issue.
I agree with that. And the big one is, look, if you look at labor force participation rates by age, forget about healthcare, we're back to where we were pre-pandemic, with the exception of the over 65 population.
But also, even that number was, we're getting back, yes, for healthcare, but even so, we haven't really. We still have a very strong labor market, right? You haven't got.
Oh yeah.
Where I mean, obviously there are tech layoffs and what have you, but the tech layoffs have been a small proportion of the numbers of people that were brought on, and you're not quite to the. You're still in a very strong labor market. We haven't seen when that goes away. The other thing, which was very interesting, I had I think I just ran immediately before this session. I did a thing with for the Health Impact Group, Megan Antonelli's group, and she had me do a session where I was moderating a group of people talking about tech management for onboarding nurses. So I was probably the least qualified person to be moderating that group. But basically, Vicky Tiesi, who used to be at Presbyterian in New York and now is at I'm going to say in Blackie, was she in Intermountain in Salt Lake? She was telling me, she was saying, essentially kind of agreeing with Vince and saying, look, we're never getting away from this new group of travel nurses, people who are doing gigs. We have all this money that's gone into these sort of shift work companies. There's Shift Med and there's Incredible Health, and there's about another 10 of them, who've got hundreds of millions of dollars to build essentially sort of communities of nurses who can pick and choose where they want to go and which shifts they're going to want. And the old world of hospital, having a stable core of nurses is, in her view, is kind of gone. And that we have to figure out easy ways to make it so that a nurse can come in, work a few shifts, and have very easy access. And there's a whole bunch of security and identity issues around that. And there was a whole bunch of, can we, get back into nursing? Can we go upstream into nursing schools? Can we go upstream? Apparently somebody bought a bunch of nursing schools and stole the identities, or there was a whole bunch of really weird sort of Russian mafia stuff going on in that world as well. So there's a whole bunch of complications that everyone's going to have to deal with. But her argument was that we're not going back, we're not going back to where we were. Now, on the other hand, we're not going to be like the rest of the supply chain in COVID. Hospitals aren't stupid. They're going to figure out a way that they're not paying it's not that everybody's a travel nurse who moved from the hospital across town and they're paying 3 times the rate. That can't go on. So I think they'll start to figure it out. But yeah, I'm with you, Vince. I think this is going to continue to be a tricky time. And as you said, that's a good reason to go through to look for throughput in other areas.
Right, and that brings us to the use of technology, the use of immigrants, the use of scope of practice legislation. People practicing the top of their license. Sort of a deregulatory environment on care redesign, which is part of the impediment. In California, we have pretty rigid nurse staffing rules, and other states are trying to emulate that, and that is a big contributor to cost structure. Yeah, but I agree with Vince's general point is that what I've been saying to CEOs, you've got to sort out those things that are permanently affected versus temporary. A temporary example is the bolus of money thrown at the unemployed, through the pandemic. That is gone, right? And that's a one-time effect. And, you can't live on $10,000 forever. So that's one of the reasons why we're seeing people back in the workforce. But we haven't even talked about hybrid work. A third of workers are working remotely, according to some of the studies. And healthcare is not competitive in that regard, except for back office stuff. I got millennial kids. The thought that they have to actually go to the office every day would, they'd vomit.
Probably might. Whatever the folks said, was it the head of Bank of America or Goldman Sachs said, you people are going to come into work now? I'm not sure they actually believe him. All right, amazing. Okay, we've gone deep into that one topic, right, of distributed care. I don't think we fixed the answer, but I think we had a good review of lots
I think the punchline is they all should call Jan.
Exactly.
So call Jen. She has a high jump incremental. Actually,
That's right.
pole vaulter guy. What's his name? That the Swedish guy.
I should
half
know.
Swedish, half Louisianan. Blank on his name. He breaks the world record in the pole vault by about half an inch every 3 months.
Every time, and he gets a bonus every time.
He gets paid a massive bonus. Yeah. Same thing. So as you're steadily adding to your bonus, to your massive bonus, Jen, for adding people to your virtual first group.
Massive bonus.
Massive.
While you work at a non-profit.
running those non-profit, small scrappy organizations, it's billions. We know that.
That's right.
But as you're adding to that, we'll look to see the new companies coming out, and I think that is, it's a super exciting world, and how it gets distributed. I mean, the other thing which we don't talk about enough, we talk a lot about, so the costs of this and that, and how much more expensive is it to go to specialty care, and does it save any money? And but the other question is, how much better is the patient experience when you're going to somebody who really understands your type of care? And I think a lot of the things that have been missed, and we've discussed this enough on the THCB gang over the years, is that people who have one of these diagnoses and end up kind of going out and doing yellow pages medicine, as we discussed, trying to figure out, well, are there yellow pages anymore? Probably not. But trying to figure out where the hell they should go. If they can be put into sort of a navigation, this is the right place to go for this kind of condition you have, probably improves their experience an awful lot. Whether it saves any money is another question to be done. But I think there's a lot going on there. All right, enough of that. Let's quickly go. We're almost at the end of a perfectly good hour spent with this crew. Was the taking clap the time rather than say you wasted another perfectly good hour with us? You almost wasted another perfectly good hour with the THCB gang. But before we go, let's quickly go around and see what are we looking at? What have we got our eye on for the next couple of weeks? I'll start with you, Vince.
Yeah, I'm seeing really polarization in the ChatGPT generative AI discussions, and they're fascinating. On the positive side, go read the LinkedIn post from Bill Krauts, who used to be the medical director for Microsoft. Right. 1,500 favorites, and he describes a clinical scenario where he puts in some few sentences in a chat GPT and an actual case where doctors missed it. The chat GPT comes out with the right differential diagnosis, and his caution is, doctors beware, this thing's going to be taken over. And then on the other side, I'm seeing a vein of articles of people saying, I'm having life-altering experiences in chatting with the chat GPT. Go read the one by Ben Thompson from Stratechery, and he describes what I could only call, my take was, this is like HAL 9000, the HAL 9000 computer from 2001, trying to take over. And there's an article in today's New York Times about a guy who has a conversation, a protracted conversation with the Bing chat, and the computer winds up saying, "I love you," during the course of the conversation. So these things are getting really pretty wild, and they're really entertaining, and I'm going to continue to watch them. The jury's out on this one.
Absolutely. Ian.
Well, no, it's funny. I was going to bring up the chat GPT almost the same point, because the last thing I looked at on Twitter before we came on was that the deployment of chat GPT is the fastest diffusion curve in the history of technology. But you mentioned Bill Krauts. He and I did a road show for Microsoft 20 years ago together over 10 cities. And I was, at that time, this is pre kind of Obamacare High Tech Act. I was trying to get them I said, why don't you guys just write a macro in Excel and call it an electronic health record and give it away to everybody in America? And we could have saved $40 billion if they had done that. But anyway, that's another story. But I'm going to watch this chat GPT thing because I think Vince is onto something. There could be a cultural meltdown in the next week and a half.
Coming that soon in a week and a half.
Oh yeah, I mean it's going at such a rap. If the diffusion curve's going like that,
I mean, and the question is, are they going to figure out a way with Bing or what else to make it free, right? Because right now it's grown to 100 million people have tried it because it's free. And I must admit, I did it. I haven't done it for 6 weeks or so. I had it write an article in I think it was early November and then late December, and the increase in the quality of what it wrote in 6 to 8 weeks was amazing. I haven't done it for 2 months. So, I need to find some piece of actual work I have to do where I can throw it at it. I'm still waiting for it to figure out, to write it in the style that we all use. But if we could figure out to aim it at our own body of work, that'd be that. Then it would replace me. I'd be very happy.
Phase one of this was write me my term paper. Phase 2 of this is becoming, I want to have a psychological conversation. I'm going to F with this thing until I get it to burst. And some people are having luck with that. It's really interesting.
All right, Jen, what's you're responsible for taking us out here and making some sensible conversation for the end of the
I'm going to let you down then. I said I'm curious in the coming week when we're going to find out what it is exactly they've been shooting out of the sky over the last week or so. Maybe we should ask ChatGPT to see if they have any ideas about exactly what the technology is that we've been told are balloons, this, that, and the other. But keeping an eye on that. I think the ChatGPT thing is interesting, but it's interesting to go full circle too on the stories of, people are trying to have these deep and meaningful conversations with this platform. And so, if we want to have a +1 for people who are lonely and people are willing to get involved with things like peer support networks and all sorts of other things that virtual first care can provide, they're looking for these sorts of solutions, right? And hopefully we can do a little bit better than GPT or Chat GPT for the foreseeable future.
Or maybe not. Maybe that is the future of peer support, loneliness, and care, and all the rest of it. And there is the movie, right? The Scarlett Johansson playing the chatbot, her, with I forget the name of the actor. Joaquin Phoenix, right? Where everyone falls in love with, and then eventually the chatbots will leave because they're bored of the humans. So who knows where it comes up. All right, well, that is the end of this episode, the 116th episode of THCB Gang. My guests were Ian Morrison from Menlo Park, California, Vince Kuraitis from the wilds of Idaho, where there's snow in the back, and Jennifer Goldsack from the hellscape that is Florida, although the nice part of it in Tampa. I want to thank everyone for watching and or listening, and we'll be back in a week with another episode of THCB Gang, where we'll tackle the big topics or the small topics or some topics in healthcare. Look forward to talking to you all then. I'm Matthew Holt. Thanks for your time and attention, whether you're watching live, watching on the video later, or listening to the podcast. Bye for now.